Thank you very much for asking me to give you an update on injectable HIV treatment regimens today. And on this slide, I've got my declarations of interest. So we're going to ask the question today about long-acting injectable HIV therapy. Where might they fit in real life? And when you talk about real life, you generally want to know how does it fit in the clinical population, including people that were never tested in the clinical trials. And we'll talk about that in a bit. So I'm going to start by giving you a couple of case studies, talking about where long-acting injections might fit in the management of HIV for our patients, an update on the later clinical trial data that we've heard from CROI this year from AIDS 2020, a little bit about drug interactions and how they might fit for special populations, and then we'll come to a summary. So let's start with a case study. So this is a patient of mine. This is a 23-year-old woman with some learning difficulties and ADHD ever since the age of 5. And the ADHD and learning difficulties have really combined to make her very forgetful, poor concentration, and has led to extremely poor adherence, poor memory for taking pills, poor clinic attendance. She's also, in addition, been binge drinking since the age of 16 and has indulged in recreational drug use, so methamphetamines, cannabis, a bit of heroin. And she really presented to us with a new HIV diagnosis on a background of recurrent STIs, so gonorrhea, chlamydia, syphilis. And it turns out she's got multiple partners. She's admitted that she does it for money. So she is a commercial sex worker. She's chaotic and forgetful. And she is happy to take treatment, but really reluctant to swallow pills. She doesn't necessarily spend a lot of time at home in the right time, at the right place. And so taking pills, regular pill-taking behavior is very difficult for her. And despite all this, she's not got any detectable resistance. She's clinically fairly asymptomatic. CD4 count is around 400. Viral load persistently elevated at around 25,000 copies per mil. So clearly, there's a lot of unprotected sex going on. There's a need for treatment for her as well. So we know that from clinical data, but also treatment as prevention. And the latter is the more urgent of the needs. Is this a patient for long-acting cabotegravir? This is a woman who would have been excluded from all the clinical trials. Okay. We spoke to the drug company about getting expanded access. That was somewhat, to my surprise, approved. And the result was pretty good. So here she was, she tendered, there was a domiciliary support, and her CD4 count went up to around 600. Her viral load came down, undetectable, stayed undetectable for the next year while we followed her up. Now, there are reasons why she is not the first person you reach for, even though in real life we would be thinking about injections for this a woman. What if she stops attending? How are you going to manage to tailor that? And you're going to have an interesting discussion about that in a bit. What if she becomes pregnant? Okay. Here's another patient on the other side of the spectrum. So this is an elderly male getting frail with a lot of multimorbidities, multiple treatment courses, and then his kidney function goes down and down and down until he gets an eGFR of around 30. He's got anxiety, depression, ischemic heart disease, hyperlipidemia, and then more recently, prostatism as well, and osteoporosis. And he presents a couple of years ago now with frailty and recurrent falls, lots of bruises. He's been unsteady on his feet, poor memory, increasingly frail, sarcopenia, and the viral load starts blipping, although there's no resistance, likely that he's forgetting to take his tablets. So is this a person that you'd consider for injectables? Okay, look at his co-medications. Notice that he's taking calcium D3, so there's calcium, there's divalent cations in the mix. Okay, lots of treatments in the past stopped because of toxicity, not failure, and currently on a boosted PI regimen. So, you know, would this be a candidate for long-acting CAB and rilpivirine? You know, neurocognitive impairment, well, that takes adherence out of the picture. Multiple DDIs, well, the gut-based drug interactions with calcium, well, that would be taken out of the picture as well. Sarcopenia, Can you inject into people with sarcopenia, you know? And I think that that's something that we need to think about in these elderly, frail patients. So then later on in the year, he gets admitted with a stroke, noticed to be fast AF, has a stroke and admitted with swallowing difficulty. So is this a candidate for long-acting injections? Well, you would say yes, except that someone started him on dabigatran for his AF. So what's the story? You know, if it was oral tablets, you wouldn't worry too much with this combination. But what about injections? You know, 2 or 3 mils each in each buttock every month, every other month. So that's worth thinking about, isn't it? Okay, he developed some seizures and is started on a moderate inducer, carbazine. What happens? What happens to his long-acting cab and rilpivirine? You know, how do you manage that drug interaction? So these are all real-life applications of long-acting therapy in scenarios that actually were not included in the clinical trials for very understandable reasons. So why the fuss about long-acting? Well, obviously we say that it improves adherence and convenient for work. If you've got a busy working life, you can do that. And that's probably the best person for this kind of therapy. But of course, when we think about injections, we think about fragile populations, the populations I've just shown you who've been excluded from clinical trials, you know, the poor adherers, the poor clinic attenders. There are other benefits as well. So there's the whole idea of pill fatigue and people not wanting to take tablets. There's the idea about concealment and privacy. There's a lot of food effects that you can get rid of, a lot of gut-based drug interactions, and there's probably a public health benefit, and we can talk about that, particularly apparent in PrEP rather than treatment. People talk about pill fatigue, but I think injection fatigue is certainly something that we will come across increasingly. It is resource intensive, and you're going to discuss how you give this in a COVID crisis. How do you manage non-adherence and the tail effects, and how do you manage drug interactions and toxicities? And I think that that's the crucial thing about an injection that you cannot actually remove that could hang around for over a year. So let me give you an update of where we are in 2020, November 2020. So you're all familiar with cabotegravir rilpivirine, the FLAIR study in naive patients. Those data were presented last year at CROI with 48 weeks and now updated to 96-week data. And again, showing exactly the same thing, that compared to in naive patients starting treatment, the injection with long-acting cab and rilpivirine was non-inferior to Triamet, dolutegravir, bacavir, 3TC, and that persists. If you look at switch patients, the people who are already suppressed, no prior resistance, switched onto cabotegravir and rilpivirine, long-acting, and you can see that that again there is no there is non-inferiority demonstrated, and that went out to 48 weeks. This was presented in CROI last year. The paper is written up in the New England Journal this year. Now, something interesting happened at 48 weeks with Atlas, with a lot of patients who were on monthly. So this was monthly cabotegravir and rilpivirine, switched over to 2 monthly. So there is a difference here around the dosing used. So the classic way of giving cabotegravir and rilpivirine is that you start an oral lead-in for a month with the oral cabotegravir and oral rilpivirine, and then you give a loading dose of 3 mils of each drug. Cabotegravir 3 mils, okay, that's 600 milligrams. Rilpivirine 3 mils, that's 900 milligrams, okay, and then that's a loading dose. And you give it your last dose of oral, and then you go on to maintenance dose with 2 mils, okay, of each. That is to say, 400 of cabotegravir and 600 of rilpivirine, okay. So that's monthly. Now, Atlas 2M was an extension phase which looked at giving cabotegravir and rilpivirine every other month, so every 8 weeks with a higher dose, with the same loading dose. That's the 3 mils, okay. And the data were good. You can see that it's non-inferior to monthly injections, all right? And these are data that were presented at CROI this year. So that's the update of cabotegravir rilpivirine used for treatment. The other really interesting thing was the HPTN083 study that was presented at AIDS 2020 this year. Now, this is not treatment. This is PrEP, okay? And this is not cabotegravir and rilpivirine. This is only cabotegravir, okay? And given at the dose every 2 months, so 600 milligrams IM every 2 months, and carried on. And this is a randomized trial to look at prevention, okay, post-exposure prophylaxis, pre-exposure prophylaxis rather, against standard of care, which is FTC tenofovir. This is a massive study, over 2,000 patients in each arm, followed up for a good period of time. And here are the data, startling data. So remember, tenofovir and FTC is a very highly effective PrEP regimen. It's highly effective. And this is even more effective than that very highly effective regimen. And you can see the difference in terms of acquisition rates over time. And there's a period up to 153 weeks data presented down here. A highly significant difference with 13 infections in the injectable CAB arm versus 39 infections in the tenofovir FTC arm, a risk reduction of 0.34. So that's a massive, massive difference here. Why that difference? Well, surely adherence must be a big part of this, okay? Here's another earlier study, HPTN077, which I won't go into too much, but this was looking at IM-CAB for PrEP, and it was exploratory, looking at the pharmacokinetics of different regimens given every 3 months or 2 months. And the interesting thing here is that it showed for cabotegravir, and the same has been showed in other studies, and also for rilpivirine, that there is a big gender and a body mass effect. Okay, so women get higher levels than men, okay? And there's also a difference by gender and by body weight. And you can see down here that the mean time to becoming undetectable was about a year in males and more than a year in females, okay? All right, so there's a big gender difference in terms of the tail of excretion. And you start to put that together, the first patient that I showed you, if she didn't turn up, she would be a very high risk of developing resistance, and so would have to be chased. Okay, I won't talk about this too much, but I think you're going to discuss the practical difficulties of scheduling of drug supply. I should say storage. So rilpivirine needs a cold chain. So, you know, can you put it in the back of a hot car and drive around town looking for patients administering domiciliary? You know, where are sterile issues? What about the logistics of giving that injection? Okay, how do you bridge when you miss clinic appointments? How do you deal with no-shows? And it's worth saying that you know, Aviv have filed and Janssen filed for licensing of Cabenuva, that's injectable cabotegravir and rilpivirine, but outside of Canada, license has not yet been granted. There is an expectation that drug interactions will be certainly different. They're not going to be the same. You can argue about whether they're more or less, but they're certainly different. So if you look at gut-based interactions, the divalent cations, oral cabotegravir, that's certainly going to be exactly the same as dolutegravir. You're going to have to manage that. And rilpivirine with the acid, well, that's going to be sorted out too with injections. Strong inducers, I think, is a no-go area, injections or orally. Moderate inducers, pretty much the same, I think. But the issue around anticoagulation, we've already mentioned, and we wait to see what the labels will say about these. What about special populations? Well, if you, and again, I make the note about the lack of licensing outside Canada. So this is from the product monograph from Canada. And we know that rilpivirine orally, there's no safety signal that we think of, and rilpivirine levels are slightly lower in third trimester, but no real I think there's no worry about rilpivirine. Cabotegravir, with all the fuss about dolutegravir, are there any data? I think we need to wait and see what data there are. Chronic renal impairment, we don't expect that any dose adjustment will be necessary, okay, for either rilpivirine or cabotegravir. Chronic liver disease, it's not been studied in Child-Pugh C, so there's always caution with Child-Pugh C. For Child-Pugh A and B, there's no dose adjustment necessary for cabotegravir. For rilpivirine, there is a slight increase in rilpivirine exposure, but probably no dose adjustment will be considered necessary. This is not high enough, I think, to get you worried about QT prolongation. So let's summarize now, because we're at the end of 15 minutes. I think that injectable long-acting therapy is transformative. It's not just a slight improvement, it's a massive improvement. And I think we don't realize this yet until it becomes available. And when we look back about it, that will be the case. It's interesting, if you look at the new drugs in the pipeline, at least half of the drugs in phase, in the preclinical development are all administered parenterally. So, 10 years ago, all the new drugs would have been oral agents, and we'd have been expecting them. But now, if you look at it, the BNABs, the GS compound 6207, islatravir, is also being developed as a long-acting implant. So I think that this is the way that a lot of people, it's not for everybody, but it's the way that it will go. And we know it's been transformative for schizophrenia, for contraception, for osteoporosis. This has really, really been a game changer in those diseases. Likewise, with HIV, I would expect that to be the case. All right. It's not either or. There will be new devices. There are skin. There are transcutaneous patches. There are other ways of delivering drug that people are looking at, implants. And I think we need to worry. And I think that that's the exciting discussion that you're going to have about how you actually deliver this in real life. There are some key unanswered questions, and pregnancy is chief amongst those. And the other big question is, the fragile populations. We really do need to give this to the right people. And with that, I will thank all my collaborators in the University of Liverpool, particularly David Back, Andrew Owen, Marco Siccardi, and the Drug Interactions team, and all our collaborators. Thank you very much, and thank you for listening.